Hello, everyone. Hi, my name is Tiara Brooks, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar, Quality Improvement 101, Part 2. This webinar is Part 2 of a three-part series. We will answer many questions within the context of Quality Improvement Project and connect the process focus from our first webinar discussion of PDSA cycles. But before we begin, we have a few housekeeping reminders. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to health care services. School-based health care is the solution bringing health care to where students already spend the majority of their time in school. When health and education come together, great things happen. Attendance improves. Conditions like asthma or diabetes are better managed. Behavioral health issues get quick expert attention. And we all know that healthy students make better learners. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. Please register today for our 2016 National School-Based Healthcare Convention and Rally. It will be held in Arlington, Virginia, June 26th through the 29th. We hope you'll join us for another year of innovative workshops and engaging speakers. Please join us on our website and register today. Now I would like to introduce our presenter today, Hunter Gatewood. Hunter is a social worker and quality improvement educator and consultant. He specializes in the intersection of quality improvement methods, management skills, and leadership development. His clients include primary care health centers, hospitals, health plans, medical groups, behavioral health agencies, grant makers, and elementary school and a high school. His clinical experience includes hospital social work and community case management for patients with high care needs related to homelessness, substance abuse, complex medical conditions, and mental illness. Thank you, everyone. I would now like to turn it over to our presenter, Hunter Gatewood.
Great. Thank you, Selena. Hi, everybody. I know a lot of you joined us last week, and want to make sure that if you were not able to join our first in the three-part series that Selena described, you're still in the right place. You're going to have a good time, I hope, and learn a lot this next hour. And for those of you who are on the first one, we're going to pick up right where we left off. So when we think about quality improvement, you really could reframe, kind of the category, all this work, what it means to improve care and operations. You could also just describe it as process improvement. And what I find is that starting with that lens, keeping the idea of restructuring processes central to the work really does help clarify what it is we're doing when we're doing quality improvement, what activities we should focus on, and how we should move forward. So that's why we decided to make part 2 all about the word, the idea, the activity, your job as a set of processes. And again, when we redesign processes, we're going for reliable results. Again, part 1 was about the Plan, Do, Study, Act cycle testing. We'll review that and cover the context that all this happens in under the model for improvement so common in healthcare and other industries as well as we go along. So if you were if you were with us last time, you know that we talked about the work of quality improvement is people who do the work, frontline staff, front desk, MAs, nurses, providers, other folks, behavioral health staff, people who actually do the work coming together to figure out how to fix the work moving into the future. Quality improvement is future focused. It's focusing on the system, the clinic as a set of processes, and the goal is, again, reliable processes that are going to get you the results that you want. It means taking time to think about what you're doing, how you're doing it, and not just trying harder and working faster and randomly testing ideas that seem like they may work and just hoping for the best. It's systematic, and it has to be done by teams. Whereas quality assurance, also very important in healthcare, quality assurance is not the same thing as quality improvement. It's important, it's complementary, but quality assurance is about inspections, audits. Usually it's somebody external coming in and telling us how we're doing things. Have we been doing things right? As distinct from quality improvement, which again is future focused. How are we redesigning care, making changes, figuring out what works from now to the future? Quality assurance is about, it can only focus on what has happened to this point. So quality assurance is about the past. Quality improvement is about taking things that weren't working as well in the past, aren't working currently, driving us crazy, not getting us the results we want, and moving into the future. So that's a good framework that helps a lot of people understand what quality improvement, or again, process improvement is or is not. I covered these main phrases, these ideas, these important concepts on the webinar last week. If you were on it, I hope you wrote these down if you aren't already familiar with these terms and how they apply to your work. Again, the system is how you can see the clinic. It's the accumulation, some of them more intentional and more recent than others. Some of our processes, some of the things that we do in our system, what the system does, how it looks, is what I think of as historic and organic. We do things because that's the way we've always done them, and that's part of our system as well. But when we talk about quality improvement, this is your opportunity to unpack a lot of the things that you do because you've always done them that way, or because you think somebody externally, a payer or a regulator, requires you to do things in a certain way. Some of those things may have changed over time. Some of your needs of your staff, your space, your patients may have changed over time. So again, the system is the collection of processes that get you the results that you get. The process are the steps that you take. Lots of people, there's individual processes, there's processes that involve multiple team members, and there's all kinds of processes. 9 times out of 10, when you're doing quality improvement work or process improvement work, you're focusing on a population. Focusing on the population helps you figure out, are you trying to fix care for everybody, just some subset of your patients, and it helps you really focus on what's important, not do things that may feel good to fix but don't really have an impact on how the results of the care, or how the care experience actually plays out for your population, for your patients. Quality improvement includes talking to these people, asking them what they need. We think we know what patients and families and kids and parents need, and mostly we're right, but their priorities and how is best to serve them, we can't know all the details without asking. So part of quality improvement is taking this population and talking to them about what's working and isn't working in visits and between visits. The concept of complex versus complicated is really important. Your system in healthcare, I can tell you across the board, every one of your clinics, all of your work, your systems are complex, meaning that they're evolving, meaning that there is no set prescription that's going to work in one clinic that's going to work in exactly the same way with the same results in your site. So when you see best practices, you can't just hear about it at a conference and go 0 to 60 and bam, implement it across the board when you get home from the conference, no matter how wonderful that idea is. You really do need to stop and, again, use the frontline team, the people who are doing the work in your system, who are in charge of the processes, to test those things out. Complicated is where there is a set prescription. If you can reproduce conditions, if you can do things in exactly the same way, then you should get the same results in every single setting. Again, that's not usually how things work in healthcare. Complicated is maybe, I don't know, a 2-day recipe for some fancy dinner that you're going to make. And so you could actually replicate that from kitchen to kitchen, place to place. And again, complex is there's no single set of solutions that works the same everywhere. Okay, and then standardization, really important idea. We'll talk a little bit about how there's often resistance to the idea of people when people think about some team or some manager trying to standardize their work. But the idea with all this, improving a process, using PDSAs, figuring out what works, the idea is that once we figure out what works, we really are going to standardize it, and people can use their creativity, use their personality, and their the art of relationships and all that. They can use that in other parts of their work, but for these particular steps, these particular processes that we've spent time fixing, it is time to standardize. So that's part of the change management and managing change. But we shouldn't shy away from talking about how to get reliable results, we need reliable processes, and we do need to standardize certain parts of the visit. This was what I described as the first kick in the head on the last week's webinar, that every system or every clinic is perfectly designed to give the results that it gets, meaning that if you can't run a list of patients you've seen in the past month, or if the kid who needs both primary physical care and behavioral health care services in the same day can't get those on the same day, or if you have a lot of unused visits, or if people have to wait for a long time to get into several days to get in to see a visit, if the first visit of the day never starts on time, your system is designed either on purpose or accidentally, your system is designed to give those results. So if you want to see different results, the whole thing, all quality improvement, is about redesigning the system. We can't redesign it all at once. Sorry if that list I just ran down stressed anybody out. These are common problems that most clinics have, so that's where that list came from. You can't fix them all at once, but quality improvement allows you to pick a few and work on them in an organized project way with the frontline team. So don't be satisfied with what you have, but don't feel like you have to fix it all at once. What is a process? Our big topic for today. You can read this, I won't read it to you. But the idea, again, is that you're going to get a specific, oops, there's a typo there, you're going to get a specific result each time. And when you think about the system level, there are many, many processes that overlap during the day, and it's important to think about those overlaps as you redesign processes. But all of care, the sum of care and the sum of, and what gets you your results is the accumulation and the way all these processes work well or do not. As I mentioned before, some people will resist standard steps. I see that resistance going away in a couple ways, and I don't like to, by the way, label people resistors. I see resistance to standardization going away when people can be shown, or at least reminded, that the decision about what to standardize and how to standardize it was the result of team-based effort, where, for example, if there's an MA who doesn't understand why she's going to do a new thing and help it with agenda setting for the visit at the beginning of a visit, for example, if she doesn't understand why that's important for her to do versus the provider who used to do it because she's already busy, thank you very much, it can help to explain that other MAs tested it. She can test it herself. She can do PDSAs herself, and that this has been shown to produce better results in keeping visits on time, for example, helping the patient feel like, helping the patients feel like they get all their needs met and that sort of thing. So if you can point to the fact that the team, not just a manager, came up with this idea to standardize something, and the fact that it works for patients and families or students, that's a great way to help people come along with those standard steps. All right, here's another, this is kick in the head number 2. You've probably, most of you may have heard this already. If you can't describe what you're doing as a process, you don't know what you are doing. Deming is the father of the model for improvement that's been adopted in healthcare. He's also the father of lean management, which he's the common ancestor of lean management and the quality improvement model. So the idea here is that as you're, particularly when you're thinking about teams in these busy, complex environments, it is really important to stop and think about the sequence of activities, who's doing the activities, and that will help you figure out ways to do things that haven't been done. We'll talk about process mapping in the second half of the webinar. One thing I love about process mapping is that it can help you figure out what you can stop doing. We can't just keep piling on more stuff all the time. So we want to figure out what we can stop doing. What are we doing that isn't working? So focusing on the process helps you figure out what your work is as a team, helps you figure out how to train new staff, and helps you figure out what's really valuable and what is and is not getting you the results you want. Okay, so those are the two kicks in the head. Hope that wasn't too terrible. Here again, is where the structure, the three big questions, and the plan, do, study, act testing wheel that are the model for improvement that govern organized, team-based quality improvement work. You've all seen this before. Please pay attention. This is the world's most animated slide as I try to show how process is all over the model for improvement and how it's the key to making the model for improvement really work and create lasting changes. So here, watch this. Okay, so we summarized on the first webinar the big three questions, right? The first question we summarized, what are we trying to accomplish as our aim? That's the what, for whom, by when. And we used some examples of aims. We are going to increase screening and services for nutrition and exercise for all of our patients, or all of our patients whose BMI is higher than we would like. That's an aim statement by December 2016, or in a school-based setting, you might want to say the school year, so June 2017. So that's an example of an aim statement. What are we going to achieve for which population, which group of patients, by what end date? And then the second big question we summarize with measures, how we know that changes an improvement. Well, we measure it. Not everything that's important to do is measurable, but we need to chart our progress. A lot of quality improvement measures are monthly. We can't just wait till the end of the year and see what happened and see what worked. We need to be able to adjust as we go, and we don't want to keep doing things that don't work. The third big question we just summarized with changes. These are the best ideas, the things you hear about at conferences, the best practices that you can research on the internet. And then the plan, do, study, act cycle is, as you know, the way we test small changes. So animation continues. Please stay with me here. So when we think about measures, a lot of measures measure a process. For a nutrition aim or related to helping patients with an elevated BMI, we need to screen them and get their BMI measure. We need to know how many people have BMI in healthy or less healthy levels. So that's a process measure, the percentage of patients who got the BMI screen within the last 6 months of the last year. And then another process measure is, of those folks who have a high BMI, what are the percentage who were referred to either a group or one-on-one counseling about nutrition and exercise? Those are both measuring our processes. Are the processes getting everybody who needs something, to get that need met? When we think about the plan, do, study, act cycle, we're actually testing usually some piece of a process with a small test of a change. So how are we going to get people to show up for those group visits once we recruit them for group visits? Do incentives work? Do raffles work? If it's a teen or adult population, can we text them? Does texting work to help people show up? We don't want to do any of that stuff if it doesn't work, but we want to add it to our process if it does. And then here's where it gets really ugly. We were talking about changes that we can make when we think about changes we can make to a process. So I hope that makes sense. Just to review measures really quickly, we went over these last time. These are some measures, these are process measures, screening measures, the process of getting a written asthma action plan for students with asthma or patients with asthma. So these are examples of process measures to reach our goals. Here is a test that we covered last time, an example of how process plays out in the PDSA. This is a way to get people to show up for groups, a mom's group from a real life project that I worked on a couple years ago where they were doing some incentives. So again, PDSAs test a part of a process in general. Sometimes PDSAs help you create a new process, but in either case, it is about developing new processes you can standardize. And just for one more perspective, one more way this might help, one way to think about it, I think about processes, especially when I work with people who haven't really thought like this in their work. They really are people who are really focused on, you know, God, in a wonderful way, in a very important way. They're focused on who comes in that day and what that individual patient or client needs. I ask them to pretend they're floating above the work, floating above the floor plan of their clinic or the community if they work out in the community, and think about all the different steps you take. Again, think about the steps of the process, the actions, who takes the actions repeatedly, day after day, visit after visit, and that's a way for people to focus on the process and the population. Sometimes this works as a way to illustrate the difference between focusing on who's on today's schedule, who comes to the door today as individuals. That's different than thinking about everybody as a population. So if that helps in your communication with your folks that you're working with, there you go. One thing in my experience, especially as a middle manager in healthcare, I like focusing on processes. One of the benefits here is that it takes the focus away from people as flawed or not doing the job right. So the blue word bubble here for the woman on the left, we often tell people to try harder. Try harder in this project. We have a year-long project. We're working on asthma care, or we're working on nutrition improvements and healthier food. Try hard during this project, and then when it's over, we can go back to normal. And that's the the worst case example, or the worst way to use quality improvement efforts. It really is about, again, trying to standardize processes, and it's not about pushing individuals to do better. It's about everybody looking at the process. One of the concepts here is if I'm brand new, if I'm a brand new medical assistant in your clinic, how easy would it be for me to know exactly what I'm supposed to do on my first day at work? And the idea is that if the processes are well designed and they've been also well documented, that it makes it really easy for me to step in as an MA on my first day and know how to work with my provider, what I put in the EHR versus someone else, you know, what the flow of that visit is like, or what the flow at the front desk is, all those sorts of things. So if the processes are established, it makes it foolproof for new staff, and it also makes it a lot easier to train those staff if you're in management. Okay, so now Selena and Tiara, we're going to start hearing more from the group. Let's do the first two poll questions, and we can also take a couple of questions that may have come in to the chat box.
Definitely, Hunter. So we would definitely give you an opportunity now to answer any questions that you may have, and we're going to start off and ask you guys a couple of questions also. The first question we have is, which of these statements is true? If we want better results, and if you can click the answers below. Now we give a couple more seconds. We see people are still entering their response. All right. So, Hunter, we have 100% that we need
this is good. Yeah,
so,
you know, this is a silly question, kind of on purpose, but think about just the day-to-day stresses at work and how busy you are. It is really easy to, if you're a individual contributor on the front lines, or if you're a manager, it's really easy to think that so-and-so's got to go, she doesn't do her job well, or we just need to push harder, and those aren't, or if we do a project, we'll fix it. Projects can fix it, but they don't automatically, and sometimes they just get in your way and give you more priorities than you already have, which is always a lot. So the reason for this kind of silly question that happily all of you got right is to help us. It's just a reminder that when in the heat of the day, in the heat of the week, when you're busy, it's easy to change your focus from processes to individual factors. Where if we stay focused on processes, we can stay out of arguments. We can really again focus on the design of the care, the process steps, and the activities versus individual people as good or bad actors. Cool, thanks. Question 2, please.
Yes. So our next poll question is, one or more processes that we do well where we have measurable results is, if you can please take a moment to put in your results. Thank you. Okay, a couple more seconds. I see you guys are still making your choices. All right, thanks everyone. All right, Hunter, the results are in.
Great, thank you. So pretty good spread. I think we allowed people to pick more than one for this one. I don't know if y'all did, but that was the way we set up the question. So there may be multiple one. There's probably, I'm sure there are people on the that are responding to the poll in your clinics where you do multiple things well. I see. Let's see. Although we have almost half the folks that said just for these 3, and again, there's lots of other things that you do well, of course. We can only pick a few for the poll, but I wanted to get an idea of specific topics. So there are quite a few folks who said they want to improve on all, or they need to improve on all of these, or they can't put numbers to it. So that's real, but that's normal. And then I'm glad to see the numbers for how well people do feel good about the work they do. They do well on completing visits within an hour. That's of course very related to process performance. It's relatively easy if you're not focusing on it to have visits run to an hour and a half between the wait for registration, the wait in the front, in the waiting room before you get called back to the exam room, waiting between getting vitalized and seeing the provider, waiting to be discharged. There's a lot of waits within a primary care visit if you're not attentive. So that's great to see people are working on that. Closing the loop on specialty referrals, that's a process step that is not commonly, where I see a lot of clinics have not focused on that. So I'm really glad to see that so many of y'all are working on that, and then, or doing well on that. And then screening patients for behavioral health needs. This is something that I know school-based health clinics do. I know some of you are not school-based health centers, but school-based health centers do better on this from what I've seen than regular family medicine and adult provider clinics. So it's great to see. Okay, good. Thank you all. So now stay on your keyboards, whoever is on the keyboard for your group participating. And let's see, do I have the screen back?
Yep. Did you want to, we did have a question come in. Would you like to answer now?
Oh yeah, let's do that. That's the next, let me move to the next slide, and then we'll take we'll take this question that's already come in, and then people can read the screen here and keep typing in other stuff. We'll take about 10 minutes here for discussion.
Okay. All righty. All right, Hunter. Let me go ahead and read this one for you.
Please, just tee them up and let me know.
Okay. Based on your experience, how do you get stakeholders to buy in, such as school administration, involved in a new process? What are the best practices you have found that work?
Great question. This is, I love these. These are change management and kind of managing up and managing laterally topics. So it's, let's see, not knowing what I'm trying to think of an example. So if you, I know a lot of school-based health centers really need more administration participation in getting parent signatures on whatever permission forms are required so that the clinic can treat the student. So a process, let's see, so a process for that could be, you want to make sure that you could try to think of something that's a process versus a one-shot thing. So you want, let's involve multiple people. You want the school administration to support your work with teachers to have the forms go out in the first week of school, and with whatever, all other kinds of paperwork. And maybe there's some resistance because there's already a whole lot of paperwork and they're worried about confusing parents or pressuring parents to do something. I don't know what the concerns may be. But concerns are valid. We have to work around them. So I would, in that situation, if the process is having teachers join your process of getting these permission forms, enrollment forms signed for your clinic, I would focus on selling the benefits of the clinic and the main lesson I guess I have here is keeping the benefit to the students central. So it's that thing about keeping the problem in the center or keeping the needs of the people that you care about together, keeping those in the center, and having it not be about, oh, the clinic wants this and the clinic wants that and they're just trying to make my life harder. So it's making sure that you start with the benefit to the students and then the barrier that not having the forms has, and always keep that central. Keep the problem central, and then it becomes less about politics and power and who's busier and all those kinds of conversations that are not productive. And then also there's the W radio station, WIIFM, if you've heard of that, the What's in It for Me. What's in it for the teachers to help you get these forms signed is that we know that students stay in class more if they're able to get care on campus. I'm sure there's other benefits that you all know very well. So I would again start with the benefit to the people that you care about in common, who are these students, and then also get to the what's in it for me.
Thanks so much, Hunter. That's all we have for right now.
Okay. Any other responses before we move on? We're going to start talking about process maps. So in that section, you can continue to ask questions as we go. But anybody else want to chat in about processes that you want to review that we might be able to use? I would try to use it as an example as we talk about process maps. So if you want your example to be what I talk about, you're all chatting in via text.
We have another
Go
question.
ahead and chat that in. Okay.
When starting off with a whole new staff to this SCH model, how do you set measures in place, especially when still dealing with startup barriers?
Good question. So I would start slowly. You don't want to roll out the top 20 priority HEDIS or UDS measures or whatever it is that a clinic that's been up and running with improvement work for years might have. I would start with, again, measures that are closely tied to the mission, why everybody wants to work in this clinic in the first place. So I would not start with, measures about reimbursement and billables and all that kind of stuff, even though that's really important and you as a manager definitely need to focus on that. I would start with a small set of measures, 3, 4, 6, depending on how easy it is for you to get these numbers. If it's easy for you to get numbers, that's great, and I would start with maybe 4 to 6 that are focused on some of the, there's the top 5 or so priority measures that the School-Based Health Alliance promotes. That's part of their big national improvement work where I have a role. Those include screening for depression, annual well child visits, those kinds of things. So again, start with something that really resonates to anybody working there about the mission of their job. I show up at work because it's important that kids get treatment, that children get risk assessments, that children get support in behavioral health, if they have depression needs, whatever those kind of things that really pull at people's heart and their mission for coming to work in the morning. Those are great measures to use. And then you can develop, and you also want to think about what you're actually going to, what's a good priority, maybe a low-hanging fruit or a high priority for improvement. You don't want to put measures in front of people, at least at the frequency of monthly, that you're not doing active improvement work on. So we want to measure what we're going to improve. So kind of a mix of the heart and mind connection, what measures matter the most to the staff, and then also what ones you're actually going to be able to commit to do organized improvement work for. And one more thought, there's measures that you as the manager need to track and monitor and start getting reports on, and that probably already is and should be a longer list. But you want to think about, again, what do the staff need to see that they can impact and that's important to them, and where you're going to help them do organized work, and then what does the management and leadership need to see. That's probably a more robust management dashboard eventually if you don't have that already.
Great, thanks, Hunter. We have a few more questions that are coming in from attendees. So if we don't get to your question today on the webinar, we're happy to follow up with you afterwards to make sure that we're answering everyone's questions. Hunter, do you want to continue with questions? We also have an example of a process, if you'd like that as well.
Why don't we try to do 2 more questions and then give me the example of the process, and in about 6 or so minutes we'll move over to process maps. That's perfect.
All right. So a question we have is, this attendee is just beginning school-based health centers, and management has complicated expectations that are not realistic in a clinical setting. The district has no clinical operation experience. They want the school-based health centers, but they have no idea about the how. What can a new clinical provider staff do to inform the education-based managers about clinical services?
Oh, really good question. A really interesting situation to be in. But congratulations for being able to launch a new school-based clinic site. That's great for your staff, great for the schools, and really good for the students. That's a real victory. So I would try to stay focused on that while you're doing this interesting negotiation. And I think I would, if maybe this is just because this is what I think about all day, but I do think it'd be valuable to focus on population health and population health measures. So there sounds like there is an opportunity to do, not the, you don't need to run them through the whole model for improvement necessarily, but there's an opportunity to say, hey, these are the top 5 or 10, I don't know, 4 or 6, however many clinical measures that will help us judge the success of our clinic program in your school over time, and this is what we are going to be focused on. And see, hopefully there's some overlap, or at least potential to make a lot of overlap between what they're asking of you and what you really want to do and what you think is going to be impactful. There's also a question of, kind of in your question, makes me wonder about sequencing of expectations, how much you can do and measure and tackle and figure out, and how many victories you can have over over what time period. So it definitely sounds like a negotiation, and it sounds like, and I would recommend using the population health lens to help the school understand what what your perspective is. They're not clinical providers. They don't do public health or population health directly, but they've obviously invested in it since they got you there now, which is, again, a great thing. So, and kind of like the other question, start with what you share as the important values, as the mission, which is the health and academic success of all these students.
Great, thanks, Hunter. This attendee also clarified that the school-based health centers are district operated. They're not associated with a healthcare entity. So Teresa, I'd love to follow up with you after the webinar to talk a little bit about what that sponsorship means. There's certainly some HIPAA-FERPA implications, and also can the providers bill. So would love to connect with you offline about that. All right, we have another question.
Yeah, let's do one more question.
Okay, before our process example, what suggestions do you have when there is a disagreement on how or when a process should be implemented?
Love this question. Brings us back to the model for improvement and the use of PDSAs. So one way to stay out of, one way to help people understand, to not argue, honestly, like within a team, you can really avoid a lot of arguments by testing everybody's different ideas. And so, and in terms of when you actually move from the testing phase to the implementation phase for a particular redesigned process, you really want to have everybody agree that it's time. When everybody agrees is the time to do it. If somebody's saying, hey, this process really works in testing with this one, I don't know, provider MA teamlet with referral to behavioral health, or with this nutrition screening and improving eating habits, with this thing that we're testing, it's really, really working over here in this one part of the clinic, or on 1 week we've been testing it. We're ready to move again from the testing phase to the implementation phase. Everybody needs to do it this way forever. We're ready to standardize the process. This is the new normal. Everybody's going to do it. If you say that and people say, wait a second, it's not time. What are you doing? You're crazy. You over there, mad scientists with your PDSA craziness. If they're not ready for that, then that tells you that I would say the best thing to do is more testing. So if there's a provider who doesn't want to do it, or if there's a medical assistant who's not ready, they we call that resistance. Often resistance is just lack of clarity, and it could be lack of buy-in. So to get clarity and to get buy-in, you allow them to test it. Okay, we're really cool. We love it over here in this little teamlet of MA and provider. We want you we understand you have reservations before you change your process to match the one we think is really great. Why don't you test it a couple times, and then you keep track of it. You help them keep track of it. You use PDSA forms. They PDSA it, and they may have some really good input. They may have good reasons why they can't do it over there, I don't know, in the afternoon, say, the same way you do it in the mornings. There could be some valid reasons that you can't standardize some piece of it, but the idea is that but you're probably going to find that hopefully they will test it and either help you make a few minor adjustments before you standardize the process, or they'll say, okay, you're right, it's cool, we figured it out, we're good now we can standardize. But you PDSA, we talk about it in different conditions, so with different staff, different times of day, different types of patients, the simpler students, the students with more complex problems and more needs, before you implement it. And then when you implement it, that's when we're in the land of, again, standardizing the new process, and that's when you do your documentation and you train all the staff and that kind of stuff. So what I can do is, I don't know, I'll send, I've got a, let's see, a sustainability plan, or no, that's not exactly the same thing. Anyway, I'll think if there are other resources, but that's the idea. You use PDSAs until everybody's on board, and don't push too hard because people's concerns are valid.
Great, thanks, Hunter. So moving on to the suggested process for your review. The suggested process was reducing no-show, same-day cancellation rates, and a process for following up with patients who are no-shows.
Okay, I love that. I do a lot of work on appointment access, so I can handle it. Thanks. It's good to think on my feet. So that's a good one. Yeah, that's good. Okay, so yeah, let's go ahead and move on, and we're going to talk about process maps. So could have had another poll question. I'm assuming some of you have done process maps before and some of you have not. But a process map, when I do them with folks, I like to use 2 different colors of Post-its and have them do it on a big piece of flip chart paper or on the wall, where they write a step of the process. So for the no-show example, maybe the first Post-it would say, there is a no-show, patient no-shows. And then the next step might be, front desk alerts provider, and then the provider decides, there's steps and there's decisions. The provider could decide whether, based on what this patient was coming in for, how urgent it is to contact that person to come back in. And so then that provider, another step would be that provider saying, this is urgent, I really needed to see this kid because she's got uncontrolled asthma, and we're adjusting her meds and doing education. So then that next step would be that the front desk or the MA or the provider herself would reach out to the patient. So those are ideas of just examples of steps of the process. The reason to do it, you're going to figure out who's doing which part in the best way. Often when you do a process map, I think the best way to do it is to try to do it with everybody at the clinic. So this requires a big meeting. If you're going to do a process map from scratch, you want to map current process first. What's everybody doing now? And then you figure out, again, like it says here, what the gaps are, what you're doing that may not be useful and you can stop doing. I love that. It's great to be able to stop doing something. And then you figure out the new process. But the current process often uncovers that people are doing things very differently. One MA does rooming and vitalizing and setting agendas very different than another MA. Providers have, a lot of variation between them based on their habits and their style. So, which is fine. That's great. Again, when you haven't sat down and redesigned a process to standardize it, you're going to uncover people doing things very differently. And so that's a fun part about it. You're like, oh, you do it that way? Why do you do it that way? And you have these great conversations, and you help decide through testing, once you have the process map, what the new process is. So, and you want to build consensus, like we talked about in that question about people not being ready to implement a new process. Okay. So the main risk, the main challenge I see with when I've done process mapping with clinics is you have to get the level right. You can be way too detailed, and it takes you all day. So that's just something to monitor as you go. No big advice there, but just something to be aware of. So here's an example of a process map. This is for FOBT. If you don't know, it's a way to do home screening for colorectal cancer. So this is an example from adult primary care, and you see process steps here. And there's the triangle, or sorry, the diamond at the top, positive, the yes or no. That's the decision. So in the example, back to the no-show, what do you do when somebody no-shows, or how do you reduce no-shows? The decision there would be, is it urgent that we see this patient? How urgently do we need to act to get this visit to happen that the patient no-showed for? So it'd be urgent, question mark, yes or no. No would mean you would, I don't know, you'd reach out to the patient or the parent within the next 3 days. Urgent would, yes for urgent. For a no-show would be you're gonna text or call immediately, or maybe try to find the kid. If it's a school-based clinic, maybe you would actually go and try to find the student in class, that kind of thing. Okay, but back to the image you're looking at here. With the FOBT cards, it's a colorectal cancer screening process where the patient takes the cards home, wipes a little bit of poop on the card, and returns the card to have it screened for cancer. So you're seeing here, the return cards are processed by the lab staff, and results are entered into the log. There's a big kapow kind of star here, and that's showing gaps in the process. So to move a little quicker, I'm going to give away the exercise. This is a better version, because in the previous version there was no follow-up. So the green boxes here show this is a future state map, the things that are added, things that have been fixed in the process to make it more reliable, where you're actually going to do follow-up phone calls when people who have been given the FOBT cards don't return them. You're going to prompt people to return them because people go home and they forget about it, or it's icky, they don't want to deal with it. So the idea here, we won't talk through all the steps, but the idea here is that when you redesign a process, you see what gaps there are. They were letting all these cards just sit out in the world and not get returned, and so they didn't know who may have cancer and who should be in the clear. So you want to be more accountable for population health. You want to add these steps. Again, same thing with, it's all about accountability and outreach. These other two green boxes show checking in on no-shows when people should come in for a colonoscopy and do not. So this is what a process map looks like. This is an example from the Environmental Protection Agency spending a day in, I wasn't involved, but they spent a day in a room figuring out a process for national enforcement of pollution standards and how they could improve accountability, surveillance, follow-up on pollution. So when you think about the EPA's work, it spans, they're federal, of course, and then the work is with states and with local organizations, local agencies. So there's a lot of ways that these pollutants that need to be found maybe are not found because of a dropped step, or they're found and not followed up on, or the right person doesn't act to enforce the standards and keep our water and our air clean. So again, process maps are important, and they can get this complicated. But I've never seen something like this in a clinic, just so you're, in case you need to be reassured. When we think, let's pause a little bit and think about the no-show example again. So no-shows, you could imagine, again, the initial post-it square for the first step could be there is a no-show. The second step is immediately the front desk alerts the provider so that she knows she can spend more time with her next appointment perhaps, or you can work in a walk-in. There's different ways to take advantage of that no-show so that you don't contribute to future appointment delays and denying care. So that provider is notified immediately. The provider again answers yes or no to the decision step represented by a diamond that says, was this an urgent visit or not? How important is it to get this patient in? And then as a result of that, if it is urgent, there's this immediate outreach. So those are about 3 or 4 process steps. And we can go more to that in the last 5 minutes if you want to keep going on that example. One more thing you should be aware of that's part of a more complex process map that is really helpful as you talk about redesigning your processes as a team is Swimlanes. And you see here, this is a school example, not a school-based health example, but an example of the steps to registering. It's a current state or a before process map for a student registering for a class. So, or sorry, for an academic program like a college program. So you'll see, you don't need to read all the boxes, but just see that the steps include multiple roles, including the student. So you could have what the patient does, what the front desk does, what the medical assistant does, what the provider does. You could add a behavioral health provider or a health educator to your swim lanes. It doesn't have to get super complex, but the idea is that there are these key handoffs that, as you know, team care, the handoffs are really important and they can be really tricky to do smoothly. But if you document them, again, me as a new MA in your clinic, if you handed me one of these that showed the process for a planned visit for nutrition counseling and education, it'd be much easier for me to do the right thing in my first day and my first week working with you to have this thing versus no training, or even versus a 2-page written outline. People like diagrams, I like diagrams. It's a great way to communicate. And also, again, to redesign the care. One thing I'll say here is that I said before, but I want to emphasize, the idea is that once you process map the current state, you come up with all of these ideas for things that are missing, outreach, phone calls, follow-up, all that kind of stuff, and then those become fodder for what you choose to do PDSA tests with. So you don't want to, no matter how obvious it is what needs to happen, I would say always use your improvement methodology and pause and have one MA, one provider, the two of them together, test the idea for what you want to change about your process before you go to implementation. It's easy in a busy environment to rush to implementation and not pause and test things because you have so much else to do and you've got a lot to keep track of and you're busy and it's a great idea and you just want to get it over with and move on. But those are often the changes that don't last because people didn't buy in, you didn't know, you didn't test it to see exactly how it would affect all the other pieces of the process. So those are the exciting changes that often dissipate over time and are really lost opportunities. So again, process maps help you generate ideas to test, and then you can draw up your final process map and use that as your new process. This is an attachment that I prepared. There's a lot of instruction on process maps available online. I found all of them too long, too detailed, just too, I don't know, irritating to use for the way that the simple way I like to do it for quality improvement, at least for starters. So I put this 2-page thing together. It's there as an attachment. There's a blue W for Word, Microsoft Word, in the control panel for GoToWebinar if you've got that. If you can download it from there, it's yours right now, or it'll be sent out with materials following the webinar and also be available with the recording link once that's up on the School-Based Health Alliance website. So process maps are fun. They're exciting. It's a really great activity to do. And again, I advise using 2 colors of Post-its, one for the steps and one for the diamond that's in orange there at the bottom of my little outline handout here. 1 color for the diamond, 1 color for each steps, and keep it simple. If you've done process mapping, there's lots of other shapes and diagrams and pieces to it, but I like to just keep it simple. The rectangle or a square is the step, and then a diamond represents a step that's a decision. All right, so we can, let's go back to, for a couple minutes, see if we can go back to if I have anything to add about the process mapping example for no-shows. So you're trying to reduce no-shows for same-day appointments. I think a couple steps could be to, as you do the outreach, would be to try to capture those folks. If they made the appointment same day, if I understood the scenario right, they made the appointment the same day, they should be fairly close at hand, or at least able to be contacted by phone to ask them why they no-showed. But I can imagine that's a really frustrating situation to be in. And yeah, I don't have anything else to say about that, but thank you for providing that example. And again, I hope the way I talked through it a few minutes ago was helpful. Any other questions for like the next 3 minutes before we wrap up?
Okay, Hunter, I'm just going to take control back. You can still allow others to answer your questions. If you have any questions, if we also just want to mention here at School-Based Health Alliance, so while you're answering your questions, let me just tell you a bit about our membership. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based health care. Our members extend and support our work. Trainings like this webinar would not be possible without you and the support of our members. We ask that you just visit our website, sbhforall.org/membership for more information. All right, and I do see now we have a question. All right, so Hunter, people would like to know the best way to get in touch with you. Is it okay if I send your information in our follow-up email to our registrars?
Sure, absolutely. I would appreciate that. Yeah, I'm happy to answer quick questions by email or depending on what you want to talk about. I'm always here. I'll just say my email, and then you'll get it in a written form. But it's Hunter, my first name, at Signal Key, SIGNAL like traffic signal, and key, KEY like door key, signalkey.com is where I'm at.
Okay, and again, the webinar recording and slides will be on the website at sbhforall.org within 3 to 5 business days. We will also send an email with the recording link with the slides and also the attachment Word document, and we will send that in the email also, let you know when it is available.
Great, and we have our third webinar in the series. It's this same time of day next week. Also on Thursday, the 21st, right? Yeah, so same day, same time next week about QIT meetings. There will be acting. We have some brave volunteers from the School-Based Health Alliance staff who are going to act out a good quality or at least an interesting quality improvement team meeting and use some of the tools we've talked about. It's going to be fantastic, so much fun. So we hope you'll join us for that. Hope you'll spread the word.
All right, perfect. Again, please enter your questions. If you have any afterthoughts, please submit those also, and we will definitely ensure they get back to you. We definitely have a few poll questions we'd like to ask you guys to give you a couple of questions right now. So let's just find out from you which processes that, one process that we are working on. If you can just please enter that for us.
And if you want to take another second and chat in the something else, we might take that as our example for our improv players team meeting acting scenario next week.
Oh, nice.
Yeah, sure, why not?
Okay, when it came to one processes that you're working on improving now or may want to soon, so far 52% says something else, 54%.
Okay. Something else wins.
No. Okay, well, we definitely want to ask you just a couple more questions. We appreciate you, Hunter, for this amazing presentation. So we'd like to ask you all, did this presentation meet your needs? If you can please just answer the question. Take a couple of seconds. All right, thank you, everyone. Our next one is, how well did the presentation meet the stated objectives? All right, and how likely are you to apply information from the presentation in your organization? Okay, and our final question is, would you recommend this webinar to others? And again, the webinar recording and slides will be available on our website in 3 to 5 business days. Okay, again, we would like to thank Hunter and all of our attendees today. We hope that you were able to take this information back with you and share with others. We appreciate you, and again, if you have any other questions, you can enter them now in the question box, and we'll try to submit those to Hunter. You also submit your questions to info@sbhforall.org, and you have a wonderful day. Thank you, everyone, for attending today's webinar. We look forward to seeing you at part 3 next week.